Today, I'm going to be talking on the current national guidelines on comprehensive abortion care in Zimbabwe. This is a very, very important talk, given the risk of maternal mortality associated with abortion in pregnancy. My talk is very short. Oh, okay. I would like to acknowledge the partners that have decided to help the Ministry of Health to come up with these guidelines, and particularly Population Services Zimbabwe. They've really taken it upon themselves to try and have the trainings for the current comprehensive abortion care guidelines spread nationwide. And in June this year, we had teams in Matabeleland North, Matabeleland South, and Bulawayo trained on the current comprehensive abortion care guidelines. And we really feel this should be cascaded down to the last district in the nation. The outline of my presentation, I'm going to look at the background of these guidelines, abortion law and policy in Zimbabwe, the stages of abortion, elements of comprehensive abortion care, the different methods of abortion management. It's been a long history. We have come far. We have pioneers of this guideline. Some of them are in this room, including Professor Chipato, Professor Zandasara, Dr. Mawire, Dr. Magwali, starting from the year 2001. 2014, we had the second guideline. If you go to the first guideline, it was mainly post-abortal care. The second guideline in 2014, it was looking at comprehensive abortion care. But it didn't have that impact in terms of being a comprehensive abortion care guideline. It still sounded like clinicians were concentrating on the post-abortion care. The 2023 guideline, which is being rolled out now, has tried to emphasize the concept of this being a comprehensive abortion care, which starts before pregnancy, during the miscarriage, and after. Looking at the background, in Africa, nearly half of all abortions that are unsafe. And almost 10% of maternal deaths in East and Southern African region are related to unsafe abortion. The WHO includes comprehensive abortion care in the list of essential services, essential healthcare services. And in Zimbabwe, the vast majority of comprehensive abortion care is provided in the public health facilities, of which half are treated in the district hospitals and a third in the central hospitals. A previous study showed that abortion complications are a major cause of maternal deaths in both the rural and the urban settings. Many women suffering from unsafe abortion or miscarriage face delays in obtaining care and may have to seek care from more than one facility before they get complete treatment. Hence, the need to decentralize post-abortal care, comprehensive abortal care. A substantial proportion of first trimester post-abortion cases are being treated using surgical methods that are not encouraged by the WHO. So what is in this guideline? The National Guidelines for Comprehensive Abortion Care in Zimbabwe is an updated, consolidated guideline which replaces the second edition. And this updated guideline provides evidence-based recommendations related to abortion care in Zimbabwe, on service delivery, abortion and post-abortion care, clinical management, and a brief background on the abortion law and policy in Zimbabwe. It contains a few recommendations and sections. However, the major areas in the second and even the first edition have not been changed. It provides a clear recommendation on task sharing, decentralization of abortion services to all levels to increase access for the women and girls. Just a brief on the abortion law and policy in the country. The Termination of Pregnancy Act, number 29 of 1977, permits the legal termination of pregnancy under the following conditions. So there's something very important in this statement. For those who know the original statement on termination of pregnancy, it stated that the termination of pregnancy is illegal in Zimbabwe, except in the following conditions. So it was tweaked a bit to try and make it more acceptable by replacing the word illegal with permits. So the abortion is permitted in only 3 conditions in our country. Where the pregnancy endangers the woman's life, where the pregnancy is what? A serious risk to the child, or the child will suffer from physical, mental defects of such a nature that they will be permanently or seriously handicapped. Or where there's a reasonable possibility on the pregnancy being conceived because of unlawful sexual intercourse. That is rape, that is incest. In that case, a magistrate must certify the conception resulted from an unlawful act. 2 physicians must certify to the superintendent of the designated hospital that the conditions exist and the pregnancy may only be terminated by a medical practitioner in a designated institution. It's very important that the pregnancy be terminated in a safe environment. I really like the way the classification was demarcated into 2. A miscarriage or an abortion is a loss of pregnancy which can occur spontaneously or it can be induced. And the induced pregnancy can be safe in the hospitals by trained personnel, or it can be unsafe abortion. And then further stage the abortion, the stages of abortion. So the first one being threatened abortion, second one being inevitable, then incomplete, complete, and then the concept of the missed miscarriage. We really feel that staging of abortion in this manner allows appropriate care depending on the stage of the abortion. The aims of the comprehensive abortion care program include provision of safe, high-quality services, including abortion, post-abortion, and family planning care. Understand each woman's particular social circumstances and individual needs, and tailor her care accordingly. address the needs of young women, reduce the number of unintended pregnancies and abortions, identify and save women with other sexual or reproductive health needs. So the elements include emergency treatment for incomplete abortion and life-threatening complications, post-abortion family planning services, counseling services, post-abortion reproductive health counseling, links to other sexual and reproductive health services, community mobilization and participation. It covers a continuum of care, which includes the general pathways of both abortion and post-abortion care, in terms of where the abortion is occurring, who is going to conduct the abortion services, and the specific guidelines for the intended interventions. So what has been updated? What's new in this guideline? The concept of the informed consent. I think if you go back, the majority of women were just told, oh, you have lost a pregnancy, we are going to take you for an evac. Now, you need to sit down with the patient, provide information to the patient, advise the patient on the different types of methods of abortion care that are available, get permission from the patient on what needs to be done, on what you have to do, and the patient will make an informed choice. And it needs to be signed before you take the patient for whatever procedure you have agreed with the patient. The concept of the emancipated minor also comes in. That patient who's considered minor, less than 18 years, normally would want to have a guardian, a parent to sign for them, or even a consultant to sign for them. Even when these people are not available, they are allowed at law now to sign for the consent for the procedure that is life-saving to them. The guideline elucidates the components of comprehensive abortion care. There are additional regimens to the medical abortion. Medication is changed, or there's addition of letrozole. I'm going to talk more on that in the next few slides. The guideline strongly discourages surgical methods for pregnancies less than 14 weeks. The tendency to just take every woman to theater because they've had a miscarriage is highly discouraged. This is coming from the WHO. For women less than 14 weeks, we can manage them medically. There is an update on the level of care at every institution. So there are tables in the guideline which tells you what cadre is able to do what for which patient. So these tables will indicate the level of care, the health provider who's giving the care, comprehensive abortion services that are given, and then at the end, they look at contraception. Just a few snippets from the table. What does the community do? What is the potential for the community? Counseling, making identification of the women who are affected and directing them to appropriate institutions. What about at the primary care facilities where we have trained nurses, the midwives, all primary care facilities, the provision of all contraceptive methods as well. There are a number of tables that are in the guidelines. I've skipped a lot of them. That's the end of the tables, where it then looks at the services provided by the specialists. All right. Which methods are available? We have medical, we have surgical. In terms of the medical management, for women with incomplete and inevitable abortions below 14 weeks, the use of misoprostol is maintained. For women with incomplete abortion more than 14 weeks, the use of misoprostol is also maintained. In terms of women with the missed abortion after 14 weeks, there are two options now. The first option is the use of mifepristone, which is an anti-progesterone, in 24 to 48 hours, followed by the use of misoprostol a day later, which can be given sublingually or vaginally every 4 hours. In addition, you can use letrozole where mifepristone is not available. For missed abortion, which is less than 14 weeks, in patients preferring medical management, mifepristone is indicated, followed by misoprostol. So the tables are there. The summary of the drugs and the regimens that are used are there. And then this one now. MVA is the surgical method of choice for women with pregnancy losses less than 14 weeks. DNE for women who have pregnancy losses above 14 weeks. And DNC, which is dilatation and curettage, has been highly discouraged in the current guidelines. I have talked about that. The advantages are known of having an MVA versus sharp curettage, reduced risk of perforations, low cost. The guideline really goes to town in trying to educate women, in the carers, in how to use the manual vacuum aspirator. In summary, most of the sections of the guidelines have not changed from the last guideline. There's an addition of the informed consent, which is very important. There's advocacy for medical management instead of surgical management in women with the first trimester miscarriage. MVA is the best, followed by DNE. DNE, that's a dilatation and evacuation, where you just use ovum forceps, or you can use the electrical vacuum. It's possible to increase the availability of access to the comprehensive care services in Zimbabwe. The guidelines are clear on who, where, and what comprehensive care services are available. And it's just a 136-page guideline. You can go through it and you'll be able to help our women accordingly. Thank you.